Hi, my name is Kelly Hampton, and I'm excited to present my DMP scholarly project entitled Ageism Awareness and Educational Intervention for Long-Term Care Nursing Staff. Here you can see the definition of ageism. You can also see how the greeting card industry feels about getting older. This is my 40th birthday card, and it shows a woman in terror at turning 40. And it's not just the greeting card industry taking shots at older people. In our youth-obsessed culture, you can find ageism everywhere. Insidious ageism has become a socially accepted attitude. It's tolerated instead of confronted. Two emerging trends are jeopardizing the ethical practice of nursing and undermining the safeguarding of human dignity. The first is the pervasive and subtle practice of ageism as an unconscious bias and stereotype threat. The second is the rapidly expanding population of adults of advanced age. Ageism permeates the social, institutional, and cultural environment, and it necessarily impacts nurses' perception and care of the older adult. Pervasive negative attitudes and stereotypical beliefs about aging seep into healthcare provision, including in long-term care facilities, predominantly serving the older adult. According to Levi et al., experiencing ageism in healthcare threatens older adults' mental health by triggering or escalating depression and anxiety symptoms. Interventions to confront ageism in healthcare are urgently needed to ensure that an adequate and humane geriatric workforce is ready and willing to meet the challenges and opportunities of a rapidly aging population. The scholarly project aimed to investigate whether an educational intervention on ageism awareness for long-term care nursing staff would improve depression symptoms in older adult patients. Secondary aims included promoting awareness of ageism in long-term care, starting the conversation, enhancing mental health and well-being in older adult patients, and increasing the healthcare workforce specializing in the care of older adults. Here's my PICO question for the project. Multiple long-term care roles ranging from bedside nurse to health facility administrator over 20 years provide me with experience and insight to be able to comprehend the older adult's position in a complex healthcare system. Encounters with the older adult inspired my PICO question. My project has a lot of significance to nursing. The internalized, unrecognized nurses' ageist attitudes can severely impact older adult health outcomes, which is especially relevant in the long-term care setting. Ageism can influence nurses' perception that all older people are the same, effectively creating roadblocks to person-centered care. Ageist stereotypes and impaired communication deters the development of a therapeutic relationship and can leave the older adult feeling isolated, anxious, and depressed. The theoretical framework for my project is Jean Watson's grand nursing theory of human caring. According to Watson, nursing's mission of caring implies that nurses have an ethical obligation to society to nurture dignity, psychosocial integrity, and to embrace others in their wholeness, even if their self-perception is fragmented. Watson said that nurses have a responsibility to sustain the practice of caring wherever it is endangered. She proposed 10 curative processes that firmly support and clarify the intent of my project and can serve as strategies to counter bias in healthcare settings. Some examples of these include the nurse exercising loving kindness or cultivating self-awareness, the nurse developing genuine, caring relationships, and the nurse accepting positive and negative feelings in self and patient. For the literature review, I did search Sinal, Medline, and Cochrane for English peer-reviewed articles using the years 2017 to 2021. You can see my key phrases here, which were narrowed down from 1,198 to 63 articles using Boolean operators. I reviewed the abstracts of the 63 articles and chose 15 articles that specifically discussed ageism in healthcare and looked at how well they could answer my PICO question. I'm going to spend a minute on the literature analysis. It's quite significant to this project. The literature taken collectively allows for a clear understanding of ageist attitudes, both in the healthcare provider and in the older adults themselves. These can exist in a vicious cycle, perpetuating ageism and creating health disparities. Ageism negatively impacts self-esteem and mental health, which can manifest as depression, anxiety, and worry. There is a consensus in literature that consistent, planned training programs on aging stereotypes, care of the older adult, and the aging process effectively decrease age bias. In the studies that questioned participants' educational level, there was a consensus that the more education the participant would have of the aging process, the less ageist they would be, so that education was a reliable predictor of ageism. The design for this quality improvement project was a quantitative quasi-experiment design with a retrospective chart review. A convenience sample included the PHQ-9, the Patient Health Questionnaire 9, results from the electronic medical records of patients receiving skilled nursing services, both in memory care and rehabilitation. Nursing staff participated in an educational intervention on ageism awareness, and the PHQ-9 scores of the patients were compared pre- and post-intervention. The project was conducted in a long-term care facility in the Midwestern United States. The facility is designed as a small house model and strives to form small, intentional communities of older adults who require various amounts of assistance in their activities of daily living, meals, medication administration, and housekeeping. Each of the 8 home-like villas welcome 8 to 10 elders who have private rooms and share common areas for dining, relaxing, and socializing. The nursing staff that participated in the educational intervention on ageism awareness included registered nurses, licensed practical nurses, and certified nursing assistants of both the female and male gender. They were employed in part-time, full-time, part-time, or PRN roles. Here is my project timeline, which began in August of 2021 and was completed in June of 2022. The budget for the project was estimated at $541.74, and you can see the breakdown of expenses here. The data collection instrument that was used for this project was the PHQ-9, the Patient Health Questionnaire 9, which provides insight into the severity of depression in patients. Federal regulations mandate that a PHQ-9 be completed quarterly for every patient in a skilled nursing facility. According to Patel et al., this questionnaire is validated as a continuous measure of depression symptoms and severity and allows for meaningful comparisons in total cognitive, affective, and somatic depressive symptoms across socioeconomic groups. As a depression severity measure, the total PHQ-9 score can range from 0 to 27. Each of the 9 items is scored from 0, not at all, to 3, nearly every day, so that you can see the higher the number, the more depression symptoms or severity the patient has. The analysis of the PHQ score 9, PHQ-9 scores of 30 patients before and after the Ageism Awareness Educational Intervention was performed using descriptive statistics. You can see that the convenient sample is consistent with the long-term care patient population, consisting of 73.3% female patients, or 22 of the sample, and 27.7, or 8 male patients. The ages of the sample spanned from 65 to 89 years old. The 60%, or 18 of the patients, were between 81 and 89. 30% were between 71 and 80, and 10%, or 3 patients, were between 65 and 70. As the Shapiro-Wilk test showed a departure from normality due to some of the PHQ scores 9s being 0, the non-parametric Wilcoxon matched pairs signed rank was used. The Wilcoxon and the median with the interquartile range was used to summarize the difference in PHQ-9 scores. These scores were compared before and after the ageism educational intervention and revealed that the PHQ-9 scores were not significantly lower after the intervention. So you can see here that after the intervention, the median was 1.0. Compared to before the intervention, the median being 2.50. We do see a change, although not statistically significant. This is a breakdown again of the pre-intervention. And remember, the higher the score, the more depression, symptoms, or severity the patient has. This project had several strengths, which included a retrospective chart design, which ensured an excellent means of evaluating the effectiveness of the educational intervention. Assessment of depression symptoms for every long-term care patient is mandated by federal and state regulations using the PHQ-9, which is a validated and reliable screening tool for depression. This was a considerable strength, and it did ensure that I had no missing data. The assessment tool and the mandate were significant strengths, as they ensured completion of depression screening using an effective screening strategy and incorporated all the PHQ-9 scores into the electronic medical record. Another strength of this project was the provision of a safe and non-threatening learning context for the educational intervention. It took place in small groups of nursing staff in the context of a conversation without leadership present, minimizing the potential for the Hawthorne effect, where a nurse may alter personal behavior or participation for fear of being negatively perceived as ageist. The educational intervention was based on the World Health Organization recommendation for dialogue as a means to recognize and challenge personal age bias. Some limitations in the project require addressing. The educational intervention occurred during the employee's paid work hours, and the facility permitted one 30-minute in-service. Implicit biases are hard to eradicate. Previous studies have demonstrated that several educational sessions are more influential for implementing exercises in recognition and awareness of age bias. Another limitation to contemplate was the project's small sample size, largely caused by the COVID-19 pandemic, which did not allow for statistical significance to be actualized. This was because a necessary reduction in the facility's patient census occurred during the pandemic, which correlated to the pre- and post-intervention periods of this project. The facility, following rules of the State Health Department, reserved an area for isolation and care of patients with COVID-19 that consisted of 10 single occupancy rooms. During the pre-intervention period, this unit was empty. Additional staffing shortages further required a reduction in census. This project offers generalizability. The target population was older adults in long-term care facilities in the United States. And the demographic of the target population is similar to the sample population in the project. Additionally, the existence of ageism is a pervasive bias in our society. Thus, older adults residing in other long-term care facilities could benefit from the implementation of ageism awareness training for nursing staff. The project is also sustainable. The results were shared with the registered nurse responsible for developing the onboarding program for new hires and executing annual in-services. The inclusion of ageism awareness during key educational occurrences for nursing staff promotes sustainability and is the legacy of this project. Looking at the implications of this project in clinical practice and healthcare policy, I'd like to point out that ageism awareness for nursing staff in long-term care facilities potentiates therapeutic relationships, which can flourish when nursing staff uphold the first provision of the Code of Ethics for Nurses, which calls for compassionate nursing care, characterized by respect for the dignity of all people. Additionally, nurses who have not confronted ingrained stereotypes of older adults show more repulsion toward geriatric nursing. Providing healthcare students and professionals opportunities to engage in implicit bias training can promote the recruitment of nursing staff dedicated to the service of older adults in long-term care. This would improve retention and staffing shortages in this industry. The project heightens the imperative of examining the institutional aspects of ageism in the healthcare system and examining policies infiltrated with age bias. The results of the project are a clarion call for federal and state mandates requiring ongoing age bias training for long-term care nursing staff. Healthcare policy must support strategic training an adequate geriatric specific healthcare workforce to ensure good health outcomes for the expanding older adult population. And I want to see here that there is currently no mandate or even encouragement to provide ageism awareness or age bias training in long-term care facilities. The finding of this project echoes prior studies demonstrating that ageism exposure harms mental health in older adults, particularly causing depression. A critical finding of the project results is that providing long-term care nursing staff with age bias training can improve depression symptoms in older adult patients. While the results of this study were not statistically significant, they are clinically significant and establish the imperative of providing nursing staff in long-term care facilities opportunities to explore internalized biases and stereotypes about aging and older adults. The project's conclusion exhort the long-term care industry to address the absence of mandatory age bias training for long-term care nursing staff, predominantly caring for older adults, despite the research that shows a detrimental impact on the mental health of older adults exposed to age bias in healthcare settings. Ageism awareness training for nursing staff can improve mental health, provide a sense of belonging, and enhance the quality of life for many older adults who will live out the remainder of their lives in long-term care facilities. This project inspires the healthcare system to rise to meet the challenges of supporting healthy aging in older adults. Thank you for your time and attention.